Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services, so I humbly urge you to sit back and spare me part of your very precious time to share some very crucial tips which you may find useful in your line of duty. Welcome. Our first question reads, Mr. R.A.R., a 47-year-old male patient with newly diagnosed cirrhosis secondary to non-alcoholic fatty liver disease, which is abbreviated as NAFLD, presents to the hepatology clinic at your hospital. He has a past medical history of type 2 diabetes mellitus and hyperlipidemia. He seeks counseling on the need for screening for hepatocellular carcinoma, which we abbreviate as HCC. So my question to you is, which of the statements below would be the best recommendation for Mr. R.A.R. regarding screening with alpha fetoprotein, which we abbreviate as AFP, concentration, and a liver ultrasonography, which we abbreviate as US, for hepatocellular carcinoma? Would it be initiate screening now, then repeat both AFP and US every 12 months? Or would you recommend he initiates screening now and then repeat both AFP and US every 6 months? Or would you recommend he initiates screening now and repeat both tests every 24 months? Or would you advise him to wait until he attains the age of 50 years, then check both AFP and US every 6 months? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. I would advise him to initiate screening now and repeat AFP and US every 6 months. Both AFP and liver ultrasonography are the most important or the most prevalent used screening tools for hepatocellular carcinoma. Due to the limited sensitivity and specificity of AFP screening, in my opinion, it should not be used alone. Now, considering its low cost and its ease of use, AFP testing in addition to US may be useful for enhancing detection of hepatocellular carcinoma. I would just like to emphasize that the American Association for the Study of Liver Disease, which is abbreviated as AASLD, and the NCCN guidelines recommend screening with ultrasonography every 6 months with an optional AFP testing for patients who are classified as at-risk patients. And these patients include those with HBV or those with HCV-induced cirrhosis, patients with non-viral causes of cirrhosis such as alcoholic cirrhosis, genetic hemochromatosis, the non-alcoholic liver fatty disease, for example, Patients with stage 4 primary biliary cholangitis, or those with alpha-1 antitrypsin deficiency, even those who are HBV carriers without cirrhosis, and even those with other causes of cirrhosis such as secondary biliary cirrhosis, Wilson's disease, or even drug-induced liver disease, just as a by the way. Now, without a history of cirrhosis, Mr. RAR is considered at risk. Now, I'll just repeat that. With a history of liver cirrhosis, Mr. RAR is considered at risk and he should be enrolled in a screening program now. Remember, a liver US with or without AFP should be repeated 6 months from the time you do it first. Now, in my opinion, RAR doesn't need to wait until he attains the age of 50 for the screening to be done. Otherwise, he would keep deteriorating. And then just like to add that he should undergo screening every 6 months and not every 12 or 24 months. That's according to guidelines. And patients with rising AFP levels, or those who have a liver mass nodule which is equal to or more than 1 mm detected on the US, should undergo further imaging with either an abdominal or a pelvic CT, or you can even consider doing MRI with contrast, just as a by the way. Let's move to the next question, please. Mr. JBB, a 64-year-old male with compensated cirrhosis, presents to your hepatology clinic. An esophageal gastroduodenoscopy, which is abbreviated as EGD, during the last appointment with your gastroenterologist confirmed 2 esophageal varices which haven't bled. He was placed on propranolol 20 milligrams twice daily for primary prophylaxis of an esophageal variceal hemorrhage. Now, shortly after the initiation of propranolol, he began feeling extremely fatigued and he also complained of weakness. A heart rate of 49 beats per minute was documented. So the propranolol grossly affected his heart rate. Now my question to you is, which of the recommendations listed below would be the best regarding Mr. JBB's continued primary prophylaxis? Would it be Nadolol 40 milligrams once daily orally, or would it be Carvedilol at a dose of 3.125 milligrams taken orally twice daily, or would you consider a transjugular intrahepatic portosystemic shunt, which is abbreviated as TIPS, or would the option be esophageal variceal ligation, abbreviated as EVL? I'll give you 10 seconds to choose the correct option. I would settle for B and administer 3.125 milligrams of Carvedilol orally twice daily, and this is the reason why. When use of a non-selective beta blocker, which is abbreviated as NSBB, is limited due to intolerance, then Carvedilol is an appropriate choice since it is generally better tolerated than propranolol or Nadolol, and its dose titration isn't guided by heart rate like the other two. And just like to emphasize that systolic blood pressure must be monitored if you opt to use it. Now, adverse effects of the non-selective beta blockers include weakness, fatigue, shortness of breath, sexual dysfunction, bradycardia, and even hypotension can ensue, and this often limit the use of these medications. Now, I'd just like to add that resting heart rate is used to guide dose titration when using such medications prophylactically, and the goal of 55 to 60 beats per minute should be targeted. Now, I would just like to add that it doesn't correlate with therapeutic benefit. EVL has supporting evidence in primary prophylaxis of variceal hemorrhage. It only targets the pathophysiology associated with variceal hemorrhage and not overall clinical compensation of the disease. Therefore, EVL should only be used in patients that don't tolerate other therapies. Now, while TPS has a role in the management of cirrhosis, for the purpose of primary prophylaxis, it's associated with worse outcomes, including increased mortality. Now, in patients with compensated cirrhosis and no varices, as proven by an EGD, primary prophylaxis, in my opinion, is not warranted. The risks don't outweigh the benefits there. Now, in patients with clinically significant portal hypertension, but without varices, the goal is to prevent clinical decompensation versus development of varices alone. Now, just like to add that from publications out there, there is sufficient data to support the use of non-selective beta blockers in preventing the formation of varices in patients in such a population, and in patients who are compensated with proven gastroesophageal varices, non-selective beta blockers are used to prevent decompensation and variceal bleeding. Primary prophylaxis is warranted in patients at a high risk of bleeding with medium or large varices, and those with small varices with what we call the red whale signs, and even those decompensated patients with small varices. Now, while preventing the first bleed in these patients is critical, it is more important to prevent clinical decompensation as a whole. So you have to look at the bigger picture. Now, non-selective beta blockers not only help prevent the first hemorrhage, but they also lower the risks of ascites and death. So they are very useful drugs. I would also like to add that EVL, non-selective beta blockers, and Carvedilol all have evidence to support their use in primary prophylaxis of variceal hemorrhage. Now, patient and provider preferences and even patient characteristics and the clinical profile of medications or the procedure should be considered before making a decision on which modality to use. I would just like to comment about disadvantages and advantages. Now, for EVL, the advantage is that there are few contraindications, but it has disadvantages such as the fact that it requires sedation to do it, and there may be need for repeated procedures. It is associated with the procedural complications and severe adverse effects. It is expensive, not everybody can afford it, and it doesn't intervene on the more global pathophysiology of portal hypertension. And of course, it requires expertise. Not every doctor can do it, and it requires greater access to care. Not every small clinic can do it. Now, when it comes to the non-selective beta blockers and Carvedilol, the advantages are easy availability, low cost, ease of administration. They are basically orally taken, and there is no need for routine follow-up EGDs. But the disadvantage is that they have unfavorable side effect profiles. There are many contraindications, and there may be inability to escalate dosing due to intolerability. Remember, the pressures may fall very low, and even the heart rate may be affected. That may limit how high you can escalate the dose. Now, while heart rate is used as a marker to titrate the doses and to assess tolerability of non-selective beta blockers, it doesn't correlate with the changes in hepatic venous pressure gradient or the clinical benefit of therapy. Those are just by the way. Let's move to the next slide, please. Mr. WTM, a 65-year-old male patient, is admitted to your general medical ward. He reports an abdominal swelling which has lasted for a week. Now, 24 hours ago, altered mental status ensued in this Mr. WTM. He has a past medical history of one episode of hematemesis, and that happened a day before his admission. He has a systolic blood pressure of 97, diastolic 61, with a heart rate of 1 or 2, a respiratory rate of 17. His temperature is 98.2 degrees Fahrenheit. Some of his pertinent physical findings include orientation to person and place. The mucous membranes are yellow and dry. Then is a report of icteric sclera. There is moderate abdominal distension with shifting dullness and a positive fluid wave. Some of the initial labs include a WBC of 8, platelet count of 105, hemoglobin of 11, hematocrit of 35%, and the ammonia is 52 millimoles per liter. The albumin is 2.28 grams per deciliter. A diagnostic paracentesis of the peritoneal fluid reveals PMN of 185 cells per microliter. An EGD shows one small esophageal varix with an adherent clot. So my question to you is, what clinical finding would prompt you to initiate a course of antibiotics in Mr. WTM's management? Would it be the esophageal variceal bleed, abbreviated as EVB? Would it be Ascites? Would it be the ammonia level of 52 millimoles per liter, or would it be the PMN levels of 185 cells per microliter? I will give you 10 seconds to choose the correct answer. So it would be the esophageal variceal bleed, EVB. Patients with the cirrhosis and gastrointestinal bleeding, including esophageal variceal bleed, EVB, are at a high risk of developing spontaneous bilateral peritonitis, which we abbreviate as SBP. Now, the use of prophylactic antibiotics in those with the EVB decreases the development of infection and reduces mortality in these patients. Ascites alone, in my opinion, is insufficient to warrant the use of antibiotics, and many patients with ascites don't necessarily develop SPB. However, prophylactic antibiotics may be warranted in patients with low protein ascites, that is, in situations where the ascitic fluid protein is below the 1.5 gram per deciliter mark, plus maybe those with the renal impairment, where that means the serum creatinine is equal to or above the 1.2 milligrams per deciliter mark, or say those with a BUN of equal to or above the 25 milligrams per deciliter mark, or in those with say a serum sodium of equal to or below the 130 milliequivalents per liter mark, or it could even be in those with the markers of liver failure, such as a Child-Pugh score of equal to or above 9, and bilirubin of equal to or above 3 milligrams per deciliter. Now, in my opinion, alternative C, ammonia levels are commonly associated with hepatic encephalopathy, abbreviated as HE, in chronic liver disease. Now, elevated levels don't facilitate diagnosis, staging, or prognosis of hepatic encephalopathy. Now, an elevation isn't an indication for antibiotics at all. The diagnosis of HE is one of exclusion. I would like to underscore that. And a normal ammonia level can prompt the reevaluation of a diagnosis of hepatic encephalopathy. Now, hepatic encephalopathy may be worsened by infection and by gastrointestinal bleeding in these patients. And the analysis of ascitic fluid through abdominal paracentesis is helpful in the diagnosis of SBP. Now, a diagnosis of SBP may be made when the PMN count, what is referred to as a polymorphonuclear leukocyte count, within the peritoneal fluid is equal to or above the 250 cells per microliter, and there is no evidence to support an intra-abdominal infection from any other source. Another alternative may be a patient with a PMN below 250 cells per microliter plus clear signs or symptoms of infection such as fever, abdominal pain, or tenderness. And such patients, in my opinion, should receive empiric antibiotic therapy. Now, SBP is an acute bacterial infection of the ascitic fluid that is associated with a high mortality, so you have to be very careful. It's also associated with a poor prognostic sign and can be life-threatening. Now, identification and prompt treatment of suspected SBP is crucial to positive patient outcomes. And prophylactic antibiotics are not warranted in those with risk factors for developing SBP. This includes even those with gastroesophageal. No, I would like to repeat that. Prophylactic antibiotics are warranted. Sorry, that was a slip of the tongue. In those with the risk factors for developing SBP, which can include patients with gastroesophageal bleeding. But I would like to emphasize that from the AMS point of view, indiscriminate use of antibiotics can lead to colonization and infection with resistant flora, and it can also promote AMR. So we have to strike a balance. Now, SBP is usually caused by a single organism. So let us not cover very broadly, even as we administer the antibiotics. Now, enteric gram-negative bacilli are the most common organisms. That is, I'm talking of E. coli and Klebsiella pneumonia. Those are the ones I have in mind. However, growing antibiotic resistance and infection related to gram-positive microorganisms and resistant organisms are also emerging. So let us not narrow ourselves to E. coli and Klebsiella alone. Let's move to the next slide. Your clinical team advocates for the approval of Terlipressin in the treatment of hepatorenal syndrome, what is abbreviated as HRS in your country. You are presenting findings from a relevant randomized controlled trial that compared the effectiveness of Terlipressin plus albumin compared to Midodrine plus Octreotide plus albumin. Now, the patients with hepatorenal syndrome were randomized to receive either of the two modes of treatment. Now, interventions were administered as per a dosing protocol until serum creatinine decreased to 1.5 milligrams per deciliter or for a maximum of 14 days. The primary endpoint was an improvement in renal function. For the primary outcome, 15 out of 27 patients in the Terli group compared to 1 out of 21 in the mid/oct group had the desired response, where the p-value was less than 0.001. Based on the information provided, what conclusions would be appropriately made? Would it be correct to conclude that midodrine plus octreotide plus albumin is significantly more effective than terlipressin plus albumin in improving renal function in patients with hepatorenal syndrome? Or would it be correct to conclude that terlipressin plus albumin is significantly more effective than midodrine plus octreotide plus albumin in improving renal function in patients with hepatorenal syndrome? Or would it be right to conclude that there is no difference in improvement of renal function in patients with hepatorenal syndrome receiving terlipressin plus albumin versus midodrine plus octreotide plus albumin? Or would you conclude that two patients with hepatorenal syndrome would need to be treated with terlipressin plus albumin versus midodrine plus octreotide plus albumin until the serum creatinine decreased to 1.5 milligrams per deciliter, or for 14 days, or to see improvement in renal function in one patient? I'll give you 10 seconds to choose the correct answer. So both answers B and D are correct. Now, in clinical trials, the likelihood of concluding there is a difference between groups when there really is none, that is making a type 1 error, is related to the value of alpha. The scientific community agrees that an outcome can be considered statistically significant if the probability of a type 1 error is less than 5%. That is, if the p-value is below 0.05. Now, the number needed to treat, which we abbreviate as N and T, is one way to evaluate study results. Now, if there is a statistically significant difference between treatments, N and T can be calculated. N and T is simply the number of patients that need to be treated with a specific therapy in order for one patient to benefit from the treatment. Now, the N and T is the inverse of the absolute risk reduction, which we abbreviate as ARR, or absolute benefit increase, which we abbreviate as ABI. So that's just a by the way to justify why B and D are correct. Let's move to the next slide. The next question reads, what is the rationale for administering both furosemide and spironolactone in the treatment of ascites? Is it prevention of hyponatremia? Is it achievement of rapid natriuresis? Is it maintenance of normal kalemia? Or is it the prevention of hypotension? I'll give you 10 seconds to choose the correct answer. So both answers B and C are correct. Achievement of rapid natriuresis and maintenance of normal kalemia. A dual diuretic regimen of spironolactone and furosemide is used to promote more rapid natriuresis than either agent alone. While spironolactone may be used as monotherapy in selected patients, furosemide isn't recommended as monotherapy because it's less efficacious. The prescribed ratio of spironolactone to furosemide is important to maintain normal kalemia. Remember, spironolactone monotherapy may result in hyperkalemia due to its inhibition of aldosterone activity. If you revise the mechanism of action, therefore, the addition of furosemide improves diuresis and causes, in quote, potassium wasting to promote normokalemia by countering the hyperkalemia caused by spironolactone. Now, spironolactone, furosemide, and the underlying pathophysiology of cirrhosis can result in hyponatremia. Patients with cirrhosis are often chronically hyponatremic. However, this rarely causes complications unless serum sodium changes rapidly with great magnitude. Now, serum sodium should be monitored in this category of patients as appropriate to minimize risks. I would just like to add that spironolactone and furosemide may cause hypotension, especially in the setting of ascites, and they should be used judiciously. Their use and mechanism of action are beneficial in circumventing the pathophysiology associated with the development of this condition called ascites, and the combination of spironolactone and furosemide in the ratio 100 milligrams of spironolactone to 40 milligrams of furosemide allows for the most efficient natriuresis while preventing the risk of hyperkalemia for the high dose, from the high dose spironolactone that we're using, 100 milligrams to be specific. Now, just like to add that though eplerenone and spironolactone belong to the same class, eplerenone isn't indicated in the management of ascites. Let's move to the next question. The next question reads, which of the statements listed below best describes the mechanism by which lactulose is used in the treatment of hyperammonemia in patients with hepatic encephalopathy, abbreviated as HE? Is it inhibits glutamate production in the GIT via inhibition of glutaminase, or is it inhibits local bacteria that produce ammonia in the intestine due to changes in the local pH from the formation of acetic acid and lactic acid? Or is it C, it increases the size of astrocytes in the central nervous system? Or is it D, it facilitates conversion of ammonia to ammonium compounds, thereby leading to ion trapping in the feces? I'll give you 10 seconds to choose the correct answer. So both answers B and D are correct. The use of lactose in the treatment of hepatic encephalopathy, which is HE, is likely multifactorial in my opinion, and it includes lactulose itself being metabolized to both lactic acid and acetic acid, and those make the local pH more acidic, thereby inhibiting bacterial growth in that area, and those bacteria are known to produce ammonia, and it also causes ion trapping of the ammonia by converting the ammonia to ammonium ions. Now the charged ammonium ions themselves can no longer be absorbed, neither can they pass through the cell membranes from within the GIT, and they are thus eliminated with feces, and that reduces the amount of ammonia present in blood, and it can reduce astrocyte swelling, not increase but reduce astrocyte swelling in the central nervous system. That makes answer C wrong. And I would just like to emphasize that answer A refers to neomycin. Now it's neomycin that is thought to inhibit glutaminase activity by reducing the formation of glutamate and ammonia in the intestines. Let's move to the next slide, please. Mrs. KPL, a 69-year-old female patient, status post-esophageal variceal hemorrhage, is admitted to your medical ICU, where she is stabilized and treated appropriately for acute variceal hemorrhage. An esophageal gastroduodenoscopy, which is abbreviated as EGD, was emergently performed, and it revealed 2 large bleeding esophageal varices. Now, these were managed by endoscopic variceal ligation, which is abbreviated as EVL. So my question to you is, which of the following would be the best recommendation for secondary prophylaxis for esophageal variceal hemorrhage in addition to continued EVL, endoscopic variceal ligation? Would it be simvastatin 40 milligrams taken at night, or would it be Nadolol 40 milligrams once daily, or would it be Carvedilol 6.25 milligrams once a day, or would you opt for 20 milligrams of propranolol twice daily alongside isosorbide mononitrate at a dose of 10 milligrams twice daily? I will give you 10 seconds to choose the correct answer. So I would opt for 40 milligrams of Nadolol taken at a dose of 40 milligrams once daily. I would just like to emphasize that the combination of EVL and the non-selective beta blockers is considered first-line therapy for prevention of rebleeding of esophageal varices. This combination is only slightly more favorable than the drug therapy alone, which indicates that drug therapy is key in combination therapy. Carvedilol provides both non-selective beta blockade and alpha-1 adrenergic receptor blockade, thereby reducing portal blood flow and causing vasodilation in both the intrahepatic and arterial circulations. Now, the reduction in hepatic venous pressure gradient is greater than that seen with propranolol or Nadolol. However, while the use of this drug Carvedilol has a role in primary prophylaxis, its use in secondary prophylaxis lacks evidence, since it hasn't been compared to the current standard of care, which is a non-selective beta blocker and EVL. Therefore, in my opinion, there is insufficient data to recommend its use in the prevention of rebleeding in patients such as this particular one. Even in the setting of primary prophylaxis, it must be used with caution due to its effects on the arterial pressures. Remember, it also has alpha-1 adrenergic receptor blockade. Now, a non-selective beta blocker plus isosorbide mononitrate is associated with greater portal pressure reductions. When you compare non-selective beta blockers alone and it is similar regarding rebleeding and mortality. However, the rate of adverse effects when you combine the two, the isosorbide mononitrate and propranolol, such as, for example, headache, lightheadedness, in my opinion, limits the utility of this dual drug therapy. I would not favor that combination D, so that makes D wrong. Pharmacotherapeutic interventions with the statins, the HMG coenzyme A reductase inhibitors to be specific, has been proposed in the setting of cirrhosis. While evidence does not support an impact on rebleeding in gastroesophageal varices, there may be some mortality overall benefits. Now, this proposed treatment may potentially target the functional component of portal hypertension by improving intrahepatic endothelial dysfunction, therefore reducing portal pressure. It can also cause improving hepatic blood flow and liver functions. Remember, statins may also target the structural component of portal hypertension via their antifibrotic properties. That is a plus. Now, evidence supporting the benefit of statins is limited, and their full utility remains unknown, but there is potential. Now, cirrhosis is associated with a high mortality risk. Portal hypertension is the seminal consequence of cirrhosis that leads to a majority of its complications, which includes, for example, the gastroesophageal varices. I would just like to add that portal hypertension includes both a structural, that is intrahepatic resistance, secondary to the fibrotic changes, the vascular distortion, and the microthrombi that form, and functional, which includes increased vascular tone due to the endothelial dysfunction, the splanchnic vasodilation, and the increased portal venous inflow that results in a variety of dysregulated neurohormonal cascades. Yeah, there are two mechanisms there. Gastroesophageal varices, I would just like to say, are present in about, if I remember well, 50% of patients with cirrhosis, but can be present in up to 85%, a staggering 85% of patients with decompensated cirrhosis. Now, the rate of variceal hemorrhage occurs at about 15% per year, and it is associated with significant mortality. Now, recurrent variceal hemorrhage occurs in about 60% of patients if not managed properly. So don't ignore this condition. If it occurs, it must be managed. Don't wish it away. Now, because of the significant risk attributed to rebleeding and death, medical and pharmacotherapeutic interventions aimed at reducing these risks are very, very, very critical in my opinion. And non-selective beta blockers, which target the functional pathophysiology, are the mainstay of treatment in portal hypertension. Beta-1 adrenergic blockade decreases portal blood flow through a decrease in cardiac output, and beta-2 adrenergic blockade decreases portal flow through splanchnic vasoconstriction through an opposed alpha adrenergic activity. So we can use combined modalities to make sure that these patients' chances of mortality are lowered. So my highly esteemed viewers and listeners, that brings us to the end of this video, which is part 44 of our pharmacotherapy MCQ series. If this video benefited you in any way, I would like to urge you to please give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I would like to humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. I'm very thankful that you continue to collaborate with me and to support me. I'm very thankful for your viewership and for your listening. I sincerely appreciate your partnership and your kind collaboration, and I look forward to interacting with you in the next video, which will be part 45 of our pharmacotherapy MCQ series. Thank you for always being there for me.